Good evening. Welcome to Week 6 Journal Club. This is Lisa. The article I chose was Interprofessional Attitudes Amongst Undergraduate Students in the Health Professions, a Longitudinal Questionnaire Survey. This article is a bit lengthy, and the reason why I chose to review this study was because I do have a strong interest in interprofessional education, and this is one of the very few studies I have come across that is longitudinal across 4 years, as opposed to the usual survey of students after a single experience. The author provides background on the use of IPE and suggests that interprofessional education, introduced at the beginning of training, attempts to prevent the formation of negative interprofessional attitudes, which may hamper future interprofessional collaboration. The potential for IPE to be successful depends to some extent on the readiness of healthcare students to learn together. When IPE works, it is known to result in teamwork. The World Health Organization advocates IPE because teamwork can be more effective than uniprofessional working. The positive impact of team working on health is greater than the sum of the contributions of individual team members. The challenge of developing effective interprofessional education that leads to high-quality teamwork is that students and professionals have difficulty with the ambiguous roles and responsibilities of staff, which results in a lack of understanding of how to work within a team. Conflicting power relationships arise from differences in professional culture, professional philosophy, educational requirements, desire for status among peers, and historical backgrounds of individual disciplines, and different administrative structures within organizations and competing priorities. Little to no data is available on interprofessional education's longitudinal effect on interprofessional practice. Does teamwork make the dream work? What is known is collaboration and team working are affected by the attitudes held by professional groups to their own and to other professions who comprise the healthcare team. This author refers to this as professional identity. For the purposes of this research, professional identity is the feeling that you are part of a medical profession. Having a professional identity allows students to behave, think, and feel like a member of the profession. It's developed through membership of a group, involves socialization where new recruits learn specific skills. For students in particular, professional identity forms in advance of training and may arise from images of health professionals in the media and socialization within the family. For example, relatives belonging to a health profession. By definition, interprofessional education is defined when two or more professionals learn with, from, and about each other to improve collaboration and quality of care. Interprofessional education is important in the development of good working relationships between different professionals by promoting positive interprofessional attitudes and behaviors. And the potential for interprofessional education to have a positive influence on interprofessional attitudes depends on the readiness of healthcare students to learn together. The objective of the research of these authors is to investigate the development of interprofessional attitudes and readiness for interprofessional learning of students in the healthcare professions from entering training to graduation. They measured changes in readiness for interprofessional learning, professional identification, and the amount of contact between students of different professional groups, and they examined longitudinally the influence of professional group, student characteristics, and participation in an IPE course. The methods to carry out their research included a longitudinal survey administered at 4 time points: on entry into their coursework, beginning of their second term, beginning of their third term, and at graduation. This was administered at 3 higher educational institutions across 8 disciplines that included dentistry, dietetics, medicine, midwifery, nursing, occupational therapy, pharmacy, and physiotherapy. The baseline survey collected demographic data such as gender, age, ethnicity, and previous healthcare experience and level of education. The survey also incorporated what's known as Readiness for Interprofessional Learning Skill, or RIPPLES, which by definition measures the student's readiness for interprofessional learning. It also incorporated the Professional Identity Scale, which measures the strength of a person's professional identity with their own professional group, and then the Contact Index, by definition, rate of amount of contact between themselves and students from each of the professional groups since completing the previous questionnaire. I don't claim to understand this well. However, in regards to the statistical analysis, the author analyzes data in the following way. A general mixed models approach was adopted for the longitudinal analysis. Associations between contact score and changes in ripples were measured using Pearson's product moment correlation coefficient. Equality of change in ripples between IPE evaluation groups was tested using generalized linear models, and the hypothesis of no change in ripples from baseline to year 2 and year 4 was tested within reaction to IPE groups based on estimates of the GLM. This table represents the response rates of students by year. The response rates decline each year, with the first year having a 86% return rate, or 1,683 responses, that dropped to 769 by year 4. The reduction in response rate over time has two causes: program attrition and not being present on the day the survey was administered. Total, at the bottom of the response rate year 1, is the average. Only those who returned the survey in year 1 were sent surveys in year 2, and so on. Physiotherapy and dietetics did not return their survey in the 4th years because of an administrative error, so no data is shown. Table 2 represents the participant demographics. The mean age was 25.1 years. 78% were females. 82% of participants reported being employed in healthcare prior to enrollment of their current program. 13% reported having earned a degree in higher education prior to enrollment in their current program. It was reported at 13%, however, I calculated 15.25%. Table 3 shows the results of changes in professional identity and readiness in interprofessional learning scores over time. Professional identity measures the feeling a person has on being part of a medical profession. The scores on the professional identity scale could range from 10 to 50, with 50 indicating the strongest identity. Ripple score measures a student's readiness for interprofessional learning. The scores on the Ripple scale could range from 19 to 95, with 95 suggesting positive attitudes towards IPE. In summary, the overall change for professional identity and Ripple scores fell in a statistically significant way, representative with a P of less than 0.001 for each. Results shown in Table 5 regarding professional identity. Pharmacy students reported the weakest professional identity on commencing their study, while dietetic students reported the strongest. The decline in professional identity scores between baseline and year 4 was statistically significant for nursing, dentistry, dietetics, and physiotherapy students. The authors conclude that it is possible that although these students may be more aware of their professional status as they approach graduation, that they may be less enthusiastic about their chosen profession overall, having experienced the realities of clinical practice. The results in Table 6 show the Ripple scores. Nursing, dietetic, and pharmacy students were the only group whose enthusiasm for interprofessional learning together did not alter significantly over time. Ripple scores for all other disciplines fell across the 4-year period, restating the author's conclusion that it is possible that although these students may be more aware of their professional status as they approach graduation, they may be less enthusiastic about their chosen profession overall, having experienced the realities of clinical practice. The results of Table 7 show the change in Ripple scores over time by students' reaction to an IPE experience in year 1. This shows that students who had the lowest Ripple scores in year 1 rated even lower in year 4. The results in Table 8 show contact scores by profession, by year, and overall. The overall mean contact score for all student disciplines was less than 0.5, with a range of 0 to 3, 0 meaning no contact, at all stages of their course. The minimal contact was reported as occurring outside the university curriculum, with social contact between students of different professions being one of the least rated forms of contact. The only professional groups that students reported substantial contact with were with nursing or medical students. It was extremely low for all other groups. An investigation into the relationship between contact scores and changes in ripples by year revealed small but positive correlations between the amounts of contact experienced with other professions and a positive change in attitudes as detected by ripples. There are many conclusions to this extensive research. What I am providing are those conclusions by the authors that I find most interesting. 1. Students embarking on a new career will identify strongly and aspire to their professional peer group. 2. The introduction of IPE at the start of a healthcare student's professional education capitalizes on the student's readiness for interprofessional learning. 3. Students entering professional education with negative attitudes towards interprofessional learning gain the least from IPE courses. An unrewarding experience in an IPE course may further reinforce their negative attitudes. 4. Having experienced the realities of clinical practice, students may be less enthusiastic about their chosen profession. This type of reality shock may even be important and useful as a match between student perceptions and the reality of practice may predict whether the student is successful as a professional. My journal question for you is, what do you think of the usefulness of administering the professional identity score serially to a program cohort? This idea would be to facilitate faculty understanding of a cohort's perceptions on the reality of a chosen profession and, where indicated, develop academic interventions to raise a cohort's aggregate professional identity score to alleviate a graduate's professional enthusiasm. I welcome all of your questions.